I'll entertain a motion to accept the agenda as disseminated.
Motion to accept.
Very good. Do we
Second.
have a second? I think I heard a second.
Yeah, I'll second it.
Okay, very good. All right, so it's been moved and properly seconded. Do we have any debate on the matter? All right, Donald, I think we're ready for the vote.
Chair Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Dr. Rosemary Jackson,
Yes.
Dr. Miller,
Yes.
Commissioner Alam, Dr. Glover, Dr. Orto, Mr. Gregorio,
Yes.
Mr. Brown, and Dr. LeBron Jackson.
Yes.
Thank you.
All right, very good. Thank you, Donna. The next agenda item is the review of our minutes from the April meeting. Hopefully everyone has had an opportunity to review those minutes. Assuming that you have, I will entertain a motion to accept those minutes unless there's a motion to amend the minutes.
Motion to accept.
Second.
Second.
All right, it's been moved and properly seconded. Unless there's debate, we're ready for the question. We're ready for the vote. Donna, we're ready for the vote on the minutes.
Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Dr. Rosemary Jackson,
Yes.
Dr. Miller,
Yes.
Commissioner Alam, Dr. Glover, Dr. Orto, Mr. Gregorio,
Yes.
Mr. Brown, Dr. LeBron Jackson.
Yes.
Thank you.
All right. Ms. Murphy, have you received any notice of any public comments for today's meeting?
Not,
Okay.
sorry, no, I have not.
Very good. Thank you. Just wanted to check in. I didn't see anything. So we'll move on to the next agenda item, which is our staff and program recognitions. So I'll give the floor at this time to our director, Director Jenkins.
Thank you so much, Chair McDougall, and good evening to this illustrious board. It brings me great pleasure to introduce you all to two individuals, one who you've heard the voice, not necessarily seen. So we're going to ask Donna Murphy to come on camera so you can get a proper visual of Donna. This is Donna Murphy. This is the Donna Murphy that I've been bragging about for the past month and a half, 2 months. And she is doing a very good job. And of course, we beg your mercy and grace as she gets fully adjusted to working with the board. But much appreciation to Donna, because believe it or not, she is still doing 2 jobs. She's doing her old job and she's taking care of the board and trying her best to take care of me. But Donna is a grown woman and can speak for herself, although she doesn't like to in public. But Donna, anything you'd like to say to the board?
Oh, thank you for welcoming me. I appreciate being here, and it's nice to meet all of you in person. And thank you.
Right. Like I said, short on words. But she is well prepared and still really, really raring to do the best job that she can for this board. And then, of course, last but not least, we have our new legal counsel to the Board of Health, Ms. Christy Malott. I want to make sure I say it right.
That's right.
Christy comes to us as no stranger to public health. I had the great privilege of working with Christy when she was the head of our child fatality task force, and I can tell you that she is someone who is very passionate about what she does. She knows the law, and she is well respected in legal circles. A resident of Rougemont and an avid runner, We are very, very grateful. When I heard that she was coming, I probably did a couple of backflips. She's a good person. And I told the leadership team and many people within the earshot that we are very lucky to have her as our counsel. But again, Christy is a wise woman and she can speak for herself. So Christy, please.
Oh, thank you,
welcome,
Director
Ms.
Jenkins. I'm really honored to be here and looking forward to serving you all.
Short on words. I love it.
Efficiency.
That means that we want to get this meeting done. So again, that's all I have, Chair McDougall. So, and then of course I want to say thank you to Nathan and Curtis for filling in as needed. They are friends of public health, and we're very grateful for their partnership. Back to you, Chair McDougall.
Awesome. Thank you, Director Jenkins. I want to echo a hearty welcome to our new participants, Donna Murphy and Attorney Christy Malott. So welcome to you both. All right, so we're going to continue on with this agenda that looks to be fairly, to provide a fairly short meeting to us. So we'll give way to Micah Gwendon for our fiscal year 23-24 third quarter PowerPoint presentation.
Thank you, Chair McDougall. Good evening, everybody.
Good evening.
Let me share my presentation. You should see my presentation without my notes. All right. So it's wonderful to be with you all again this evening to discuss quarter three of the 23-24 fiscal year. Jump right in. The Department of Public Health's original budget for 23-24, this is the number that doesn't change every time I present to you all. It's $28,966,535. Since July 1, 2023, $7,208,274 has been added in expenditures from budget amendments as well as rollover funds, and $4,333,561 has been added in offsetting revenue from various budget amendments. Thus, the revised budget for 23-24 is $31,841,248. The Department of Public Health has spent $24,342,790 thus far this fiscal year. This number excludes benefits, making up 53% of our overall expense budget. And this number does also include encumbered contracts for the remainder of the year. This graph here shows the percent of budget used by the top 10 divisions with the highest spending. The percent spent is along the side on the y-axis, and a rough estimate of the expenditure budget is across the bottom on that x-axis. Using this chart, you can see the various spending of these cost centers. In general inspections has spent 83% of their budget. Dental and our Dine cost centers have both spent 79%. STI has spent 77%, and so on. These figures also include funds earmarked for contracts through the remainder of the year. This graph that I show you each quarter is getting very busy now that we have 9 months under our belt. This is expenditures by month and type, but for this evening, I'm only showing data for quarter 3 months, January, February, and March. So during quarter 3, our lab and medical supplies totaled approximately $106,500. Notably, we purchased a freezer for immunizations, a steam sterilizer for dental, and completed service and maintenance on our analyzer in the lab. Those costs are showing up here in our maintenance and repair and equipment lines. As we look at this fiscal year versus last fiscal year, we see our personnel costs are slightly higher due to the class and compensation changes that were made for the current year by the county. We're spending less on contracts this year than last year at this time. We think that's due mainly to a decrease in a couple of our large COVID awards that we had in fiscal year 23. We do have changes in supply costs, both in pharmacy and lab, and they do look insignificant on this graph, but we are seeing an increase in those costs. On the revenue front, we've brought in $8,054,530 in revenue, making up 57% of the revenue budget. Medicaid remains the highest revenue source for the department. Year to date, we brought in, or I should say through quarter three, we brought in $4,264,683. Our grant revenues total $3,179,473, and service fees total $383,965 to date. This chart was also getting very busy as we move into the second half of the fiscal year. So we reworked it a little bit to show you which cost centers have generated the most revenue for the third quarter. So administration, pregnancy care management, maternal health, and child health are the cost centers that generated the most revenue each quarter. These small boxes within the area show you the months. And on the revenue side, when we look at last year versus this year, the places that we see major differences are again related to the COVID dollars and where we had large COVID dollars last fiscal year, and that's in school health and tuberculosis. So as always, I appreciate the board's attention to our fiscal matters, and I'm happy to take any questions that you may have at this time.
Any questions, board? All right, Michael, well, we once again thank you for a very thorough presentation and very informative as well. We appreciate it. All right, so we're moving on with our agenda. We have next a presentation on our FIT update that will be given to us by, I believe this Quanisha Archer.
Yes, thank you.
Hi, Ms. Archer. The floor is yours.
Okay, and you all should be seeing my presentation on FIT, which is Formerly Incarcerated Transition Program. I just want to confirm that everyone can also hear me okay. All right. And so the FIT program, this is just showing our statewide efforts. FIT is a program that supports those that are released from incarceration within the last 2 years that do not have medical coverage but have chronic health conditions. They are referred to us to support and kind of fill in the gaps of covering the cost of their care. Durham was the first county in North Carolina to implement FIT, and that was in 2017. And that at that time, they were grant funded positions, and thankfully now I have 2 county positions that are with Durham. FIT is a part of UNC with Dr. Evan Askins running the program. Since being able to implement it and having efforts to support it statewide, he has been able to implement it in Wake County, Orange County, Mecklenburg County, Guilford, and New Hanover County. In addition to the regular FIT program, since being able to advocate for additional services, there are also programs called FIT Recovery. And FIT Recovery supports those. We work with Orange County Correctional as well as the Women's Prison in Raleigh, and supports those with opioid use disorder. they are able to start their treatment within a couple of weeks of their release. And then once they are released and they come to Durham County, we connect them with Lincoln and they're able to continue on immediately with maintaining their treatment for opioid use disorder. And then Dr. Askins has also implemented what is called Fit Wellness, and currently Fit Wellness supports those that are released with more severe mental health needs. And that is a trial program that is based out of Wake County at this time. However, February of this year, the Department of Health and Human Services approved funding of an additional $5.5 million to the program for UNC to work on expanding Fit Wellness to Durham County, Orange County, and New Hanover County. And at this time, the expansion will be monitored by UNC, having those positions governed by them to support services that they will put in place actually out of Orange County to support those that are in that program. FIT is modeled after a nationwide model called from the Transition Clinic Network, which is based out of California. This is an evidence-based program that was in place in California, working very well, and showed how those returning from incarceration, when connected to community health workers and peer supports, they had a better chance of preventing recidivism. They were being connected to services faster and able to successfully navigate with the support of someone with lived experience, helping them to become familiar back with society. Since this, TCN, or Transition Clinic Network, has implemented 48 community-based primary programs in 14 different states as well as Puerto Rico. I just want to speak to the picture that's included because that is all of North Carolina staff that was able to go out this year to California for a conference, and we were able to gather information on how California has expanded their Medicaid, how they have benefited from being able to allow their community health workers to build Medicaid and draw down that additional funding to support the growth of the program. And we were able to get additional information on harm reduction resources that we could start the process and see how we could implement some of those things in North Carolina as well. So with formerly incarcerated transition or FIT, the community health workers provide various services. It ranges from things of just being a peer support in some ways because they themselves have had a previous experience with incarceration or being in jail, and they can help to kind of model that change behavior and help those that we are serving understand how to navigate the healthcare world. We connect them with Lincoln Community Health Center because they serve as the primary care provider for our clients that are in Durham County. And we have FIT vouchers that are funded by the funds that UNC manages, and that covers the cost of care provided by Lincoln Community Health Center. The community health worker assigned to the clients attends the medical appointments with the clients, as well as helping them connect to other resources because we're assessing their well-being needs all around. So it could be housing, food security, medical insurance. We're making sure that they are connected to whatever resources that are needed before we close their cases. So just looking at Durham stats overall, since 2017, Durham has supported more than 300 formerly incarcerated residents through this program. Nearly half of those cases, in fact, over half of those cases have closed successfully, either with the client reaching a status where they felt they were comfortable navigating services because we had provided enough information, or they reached what we called with FIT gold status, meaning they were thriving in all social determinants of health. They had stable housing, they had a steady source of income, they had then transitioned from the vouchers to having their own health insurance and was able to manage their healthcare needs and other ongoing needs. Currently, we have 43 active clients, and we have one new referral that is being set up for intake. We have been receiving about 4 new referrals a month since January. Since January 2024, of those that we have received, 14 out of the 16 new clients have been connected to either Medicaid or Medicare, and this has been a great benefit of Medicaid expansion. We've been able to connect clients within at least 2 months to Medicaid, and then we continue to support them in understanding their Medicaid benefits and helping them to continue to navigate. We don't close the case just because they have Medicaid in place or Medicare. We make sure they're understanding those benefits before we transition them out of the program. So just want to take some time to put things into perspective. Let's say you are 35-year-old, recently released after 15 years, and you have high blood pressure and diabetes. You are not employed and you have to pay $700 a month to maintain your housing, in addition to $40 of probation fees. So a referral to FIT would help them by us doing a thorough intake to fully understand what their healthcare needs are. After we process all of their consents and make sure that they understand the program, we would call a contact that we have at Lincoln that gets them an appointment sooner than them trying to navigate it on their own. From there, we would make them their appointment. We would also take them over to DSS or sit downstairs with them and make sure that their Medicaid and food stamp applications were completed thoroughly and get those submitted to start the process of them becoming eligible for those benefits. We would then make sure that we connect them to NC Works or the local reentry council to make sure that they have a connection to some of the second chance employment opportunities to try to help them with the fact that they are recently released, but they already have bills coming in because they have to maintain their own housing. We would also follow up with them, making sure that they have transportation resources in place to get them to their appointments. And then a community health worker that's assigned to them would attend that initial appointment with them, making sure that they understood what the doctors are processing with them, making sure they understand their prescriptions and their aftercare plans, and that they felt comfortable with the doctor that was assigned to them. They feel like they can continue to share what their health concerns are, and they feel like they're being heard. And then from there, we would also provide them with the vouchers that would cover the cost so that they're not encumbering additional financial obligations while they are unemployed. And then that will continue to be the support that is provided until that person becomes more stable and therefore also becomes insured. Just another perspective or thought, let's say you're 75 and you have served 50 years in prison, as this has been something that we have seen quite frequently in the past 6 months. And you have been released and you have no family in this area or no support, or possibly no family that you're well connected to that are still living. You have several chronic health problems and you don't understand the different parts of Medicare or how to get transportation. You're receiving medical bills, but you don't understand because you have Medicare Part B, you're not understanding why you're still getting bills. Your income is about $948 a month. You have $19 of food and nutrition service or food stamps, and you also have to pay about $700 a month to rent a room. So FIT services for this client who already is insured with partial Medicare, we would consider this client someone who is underinsured, and we will continue to support them in understanding their bills, try to connect them to resources like Duke Charity Care to try to see if they're eligible for things to offset some of those costs. We will continue to try to process with them Medicaid if they are not already receiving the Medicaid in addition to Medicare. We also connect them to resources such as senior pharmacists to try to help them better understand their Medicare options, and also try to help them secure additional parts of Medicare, because when you have spent 50 years in prison, you're not going to have the work history that makes you eligible for all parts of Medicare. And so we have to process that with them and see what other avenues can be used to still support this person's well-being needs. We also make sure they're connected to food banks and things, because the minimum amount of food and nutrition service that they're eligible for may still create some food insecurities for them. So we try to make sure that we're looking at the person, not just for the lens of what their medical needs are, but looking at all of their needs and trying to connect them to as many resources as possible and continuing to work with that person until they are stable. All of these things are in place and they're part of the model because it helps to minimize reincarceration of those that are released. And this is just to give an overview of how we do community networking to make sure that our services continue to be known in the community. Prior to COVID, you could do in-reach and go into the prisons, into the jails, but of course, a lot of that shifted with COVID, and it's still kind of a different process to try to get entry into the prisons to inform prior to release of the services. So we do a lot of community networking. We partner with our community resources. A lot of our referrals come from Justice Services or the LRC, the city program Welcome Home. We go out and speak with those that own transitional living homes to make sure that they are aware of this service so that when they accept someone into their home, they can also make referrals. We do receive referrals from the detention center, and we welcome self-referrals as well as clients hear about services. And we just want to make sure that they understand what is in place and that they can remain connected to FIT until they are in a more stable place. And I just want to reference in the picture, because some on the call may be aware that this is Darrell Clayton in the picture with myself, and we were out doing a community event. Darrell Clayton used to be the main FIT community health worker. However, he is now still a part of the FIT world, but he was able to transition to Transition Clinic Network, which FIT is modeled out of, and he now serves as the national trainer or the community health worker lead. So he trains the new community health workers that we employ here in Durham and continues to train and support FIT community health workers in North Carolina. And so just advocating and using that model, that transitional model, we've been able to provide community health worker positions for those with lived experience of incarceration nationwide, and it's over 100 positions now supporting these programs. So thank you for the opportunity to provide more information on the FIT program. I'll open it up for any questions that may have come up.
Ms. Archer, go ahead.
Go ahead, Rob.
Dr. Ray. I have one quick question. On an average, what is the average time frame that one would expect, or that you would expect, to have a formerly incarcerated individual that participates in the FIT program to then be able to come or be disconnected from the FIT program because they have employment, they have insurance, all the things that allow them to be disconnected? What kind of time frame on average are we looking at for those things to be accomplished?
Now, prior to Medicaid expansion, there were some that needed to remain on the program for 3 years or more. However, since Medicaid expansion and also since there have been, we have connection with those at NC Works that do a lot of advocating for second chance employment, and we work very closely with Justice Services or LRC. We have seen that shift tremendously, and I'm seeing some of the clients that I've had referred in January are already seeing them progress to a more stable place. They have their insurance in place. We may be working with them to kind of process and understand that sometimes not all medication that they need is covered by Medicaid. So we work with them through things like that to process, okay, when to advocate for a different medication or minimal things like that. But many of them are either already employed or they're working with Justice Services or LRC to do the employment classes and gain better skill set to become more employable. And so we're seeing it shift from people needing to be on the program for 3 years to looking at where we could definitely see more people being able to close cases within 6 months to a year, just because of the fact we are able to connect them to insurance within 2 months at this point.
It is awesome. An awesome program in general, but that's great with the Medicaid expansion that you're able to accomplish at least the insurance piece a lot quicker.
Yes.
Dr. Ray, you had a question. Thank you, Ms. Archer.
Yeah, just a quick question. First of all, thank you for this presentation. Very wonderful program. I think you addressed in some of those examples, but just wondering sort of the main avenues where these patients seek care. Is it mainly through Lincoln, through providers at Duke, UNC? Just wondering sort of where what is the most common place where these folks seek their primary and specialty care for their health, chronic healthcare needs?
Okay, so part of the model is that you have a dedicated clinic that will serve as their primary health care. And so for Durham, it is Lincoln. However, of course, when they need additional needs, because many do, we get them connected to Duke and other services like that for their specialty care. And then that's where it comes into play, where we make sure they have things like Duke Charity Care and things in place to help offset the cost of those, so they're not encumbering additional bills to maintain their health.
Great, thank you. And then just one more question around, you mentioned vouchers that would be available. Are there like, I'm just trying to picture like what a voucher is. Is that essentially something that the clinic can use to then say bill the county for those funds that the patient would normally pay, or how does that work?
And so with it, the county isn't being billed, thankfully, because UNC manages the funding part. They maintain grants and things and continue to advocate for grants to cover the cost. The vouchers is just a form that Lincoln needs for their procedures. And so essentially, when we go to the clinic with a client, we give them a voucher confirming that they are eligible for FIT. I also maintain a list and give it to Lincoln monthly to say these are our active clients, so that anytime a client comes for something urgently that they haven't been able to make it here for a voucher, Lincoln's financial department knows that they are an active FIT client, and it won't delay them getting their services. And so essentially it is literally just a voucher saying that they are a FIT client, confirming that they are still active, and they attach it to their bill. Lincoln does their processing internally, and then they send that invoice to UNC, and UNC as the partner for the financial part of FIT covers that cost.
Fantastic. Thank you so much for the presentation. Really appreciate it.
Thank you all.
Yeah, hi, this is Rosemary Jackson. I have a question. I actually work with the prison system. So do you find that when they're released, are they coming to you with medical summaries, with a 30-day supply at least of their meds from the time that they've been in prison? Because like you said, some have been there a long time.
Right.
And some of them are very sick while they're in prison.
Right, exactly.
And I'm prejudiced, but the prison does a great job with healthcare in North Carolina. But are they being released with what they're supposed to have? Because they're supposed to be released with meds and with their medication summary, their medical history.
It varies. We don't often get their medical summaries, but we do work with them immediately and trying to complete the request to get that information sent over. Now, those that work with us through the FIT recovery program, UNC has someone who works directly with those two prisons that are part of the FIT recovery program, and we can get their records a little bit easier. However, others that are just released that are coming in for other various conditions, they don't often have their actual medical summaries with them. And it varies as far as the release with the medication. We have quite a few that will be released with 30-day supply, and then some that are not.
Okay.
And so the way we just process it is when we get the referrals and we do that intake, we process that with them up front. If they have a 30-day supply and we have someone else that doesn't have any, we ask the clinic for a slot for that person that doesn't have their meds first. And then we work the other person into, because we do have limited slots.
Okay. Okay. Yeah, I'll go back and look into that. About our process for making sure that they get those meds and those summaries. Sometimes they're in such a hurry to get out of there. Sometimes they have to wait a little while, and they are not waiting. The cart is out front, and they'll leave, but they're supposed to. All right, thank you so much. That's a great program.
Thank you.
Thanks for your presentation.
And I see Dr. Jackson, Lauren Jackson has a hand up as well.
Thank you, Ms. Archer, for that presentation. A wonderful program. I have the opportunity to work with Evan in the Department of Family Medicine at UNC, and just really committed to continuing doing that great work. But I did have a question, and you alluded to some of this earlier about clients who may be waiting to enter the FIT program. And typically, what is the wait process like? How do you have a waiting list? How are those folks supported if they are waiting?
currently we do not have a waiting list. We have one that it was waiting for intake, and it was solely because the community health worker was reaching out trying to get the person scheduled. And we were having a hard time getting the person to respond back, but I actually have received confirmation that that person that was pending has scheduled their intake for next week, so we can go ahead and start the process of completing everything and getting that person in services. But prior to, like I said, I have two positions. They were both vacant for a while, and I then supported the program, but it still wasn't a wait for that because the referrals came in. I just did the intakes and everything and got them connected to the services. And now I have one that started in January, and hopefully will fill the other position this month. And then we'll be fully staffed, and it won't be a wait necessarily, because if it gets to a point where our numbers increase too much, I would be able to step in and still kind of cover that to make sure people were getting connected timely.
Awesome. Thank you, Ms.
All right.
Archer. Do we have any other hands up? Any other questions for Ms. Archer before we move on to the next agenda item? Okay, well, very good. Thank you again
Right.
for a wonderful presentation about a fantastic program. I wasn't as aware of the program, but I certainly have a better understanding now, and much needed, very, very good program that's in place there. And I'm proud
Thank
that
you.
Durham County was the first in the state to implement it. So that's another feather in our cap. So, all right. So we're going to move on to, well, it says health director's report, but then we have the health director's report at the end of the three items. So we're going to start with the vacancy report, which I'm calling it as though it were Dr. Jenkins.
Speak it into existence.
Speaking into existence. That's right. So, Director Jenkins, I'll let you have the floor to present the vacancy report. If there's anything you'd like to highlight with that issue this month.
Not much, and thank you for that. Thank you for speaking that to the existence. As I
Speaking
said,
into existence.
Rosemary Jackson, 45 to 60 days. 45 to 60 days.
Awesome.
We hold steady at 14.1%. We have had quite a week in which individuals are going on to their greater purpose, and that's fine. However, very proud, continue to be proud month after month of our nursing administration and the great job that they've done filling all vacancies for our school health nurses. They're just knocking it out the park, and I do expect for this vacancy percentage to decrease because we have so many positions that are filled. However, we have had a number of resignations for whatever reason, birth of a child, better opportunity, whatever have you, but just not necessarily going to another employer, employer for public health. So that does my heart a little bit good, but that's all I have for the vacancy report.
Okay, very good. Yeah, I noticed that it's down compared to last week, back down to the 14.1, so that's great. Our next item on the agenda is to look over the NOV report. So I think I saw Mr. Salter on the call. Mr. Salter, if you want to address, it looked fairly standard, at least in the last few months, but go ahead.
Yes, sir. There are no major changes. I think we added 2 and were able to remove 1. But there are a couple of positive things here. If you look in the active list, there are several NOVs that have been indicated. They're in an area that is being considered for sewer expansion. And there are a couple that are actually just waiting for connection. And that's always the positive solution that we're looking for, because that is the permanent solution to this problem. And so that is a positive outlook on this report.
Awesome. So do we have any idea of the time frame where those cases might be connected?
No, I wish I had a crystal ball for that, but it's just development continues to just explode in Durham. And on that same note, if if you aren't aware of what's going on the eastern side of this county, you might want to take a Sunday leisurely ride out around the Olive Branch and Coley Road area, which has for decades been nothing but wooded area and a house here and there. And there are massive developments going in back there. If you're not aware of it, it's worth taking a ride and taking a look at what's happening over there.
Okay.
But that kind of development and you know,
Slows it down.
there's yeah, it certainly does. And we do not have, the city can't tell us exactly when. It's just it's a process, to say the least,
Sure.
right now.
Sure. All right. Well, I saw a lot of green at the end of the report, so I'm always thrilled to see those cases that are completed. So very good. Thank you, Mr.
Right.
Salter. We appreciate that.
Thank you.
And then finally, with this subsection of this agenda item, we have the health director's report. So Director Jenkins will give you the floor once again.
I
to
promise
highlight.
you, Chair McDougall and the rest of the board, we're going to get it all squared away. But
right.
the health director's report is very robust this time, no shortage of activity. And I tend to get in trouble when I point out, one or the other, but lots of great work going on with our diet and nutrition. The third floor at one point in time smelled like a greenhouse because we had so much fresh soil from them doing the kits for the kids. And that always warms my heart because they're learning about food and how it's made and everything and making food of their own. So, hats off to Rachel Elledge and the nutrition team. And of course, two programs that were high on my to-do list as far as budgetary preparation for fiscal year 24-25. Bull City Strong, which is our health literacy. And then, of course, ACEs, the work that Jess Pasquette is doing with ACEs is really taking off. I had the great privilege of being at a state Smart Start conference this week in Guilford County, just as part of being the vice chair of our Durham Partnership for Children, and a lot of work around ACEs. So I really was just tapping my chest and saying, "Hey, we got this covered. We're doing a lot of great work with ACEs and beyond." So we're trying our best to get Jess the support that she needs. But again, as evidence inside the health director's report, lots and lots of great work going on. And then, of course, we do have, again, our dental activity last month at the Women's Health Conference held at Hillside High School in conjunction with a number of different vendors. They were there on site to do dental screenings. So it did my heart well to be in the midst with them and just kind of see them in action. But a lot of good work going on. So very, very grateful for the staff for putting it together so you all could really see their great work.
Thank you. Yeah, I was looking through the report and did kind of get fixated on the Bull City Strong program, and really impressed by what over 57,000 residents being positively impacted by that program. So that's quite impressive. And of course, as a dentist, I had to spend a little bit of extra time on the dental work that's being done through the Women's Health Awareness Conference. I did have a question regarding that, though. With and I see that the dental clinic is going to be participating in this conference next year, and I'm assuming it's going to be at Hillside, maybe not. But is there an opportunity for local dentists? And Dr. Harris, I know, is on the call, so anyone of you can answer. But is there any opportunity for local dentists, benevolent providers that might be interested in participating? Is there a way that they could participate in such an activity?
I'd say being very familiar with how it's organized, and again, just giving a huge shout out to Willa Allen Robinson, who is on the main committee. I would say yes. There is plenty of opportunities. They will make space for benevolent care. Not on the scales of the missions of mercy, so to speak, but they'll definitely have an opportunity for you and your colleagues to participate if you so desire.
And how would we go about plugging into the health department to take advantage of those opportunities? What's the best way to do that?
We would connect you with Willa, and
Okay.
Willa makes it happen.
All right. All right. I know she does. I know she does. Fantastic job. All right. Are there any other questions or comments? Fantastic work, obviously, that continues to be done through our health department, and very exhaustive report this month. So thank you, Director Jenkins.
Absolutely.
All right. I don't see any hands up, so we're going to move on. We don't have any committee reports today and no old business. So we're moving on through the agenda. Our new business. I'd like to ask the board to give us some input. What would you like for us to maybe discuss, or what presentations would you be interested in seeing at our next meeting, our June meeting? Any comments? Any suggestions?
I have a general question.
Yes, ma'am.
I recently heard an excellent presentation about the use of telehealth services, and I didn't know if that had a role, or that could play a role within the health department, or does it exist, and what sort of forms? And so I would be interested in learning more about that.
More than happy to get that for you, Dr. Jackson. We were proud to say we were a little ahead of the curve with COVID on a number of fronts, to include telecommute activity and also telehealth. So coming in, getting organized, having a staff that was proactive with that, but more than happy to give you a brief update on our telehealth apparatus. More than happy to get that for you.
Thank you.
So any other suggestions on items that we might have presented at the next meeting? So I don't know if this is appropriate. I know we're still trying to figure out the funding and exactly what the funding will be and how it will be used. But with the fentanyl grant that we've gotten from the federal government, could we get perhaps an update on that, where
Absolutely.
we are as far as resources and how they're being utilized?
More than happy to do it. I will give praise to Deputy Director Christian Patterson, who is actually had attended one of the updates today with the statewide opioid activity sponsored by the North Carolina Association of County Commissioners. So happy to provide you all with a brief update on that as well.
Okay, awesome. All right. Any other suggestions? All right, folks, we're moving quickly. Our next agenda item is informal discussion. So I'll give the floor to anyone who would like to make a statement or ask a question about anything in general. And seeing no hands go up, I will now entertain a motion to adjourn. This might be the shortest meeting I've chaired, at least, but I'll entertain that motion.
So moved.
Motion seconded.
You guys don't sound excited to leave at all. Very good. It's been moved and properly seconded. I won't delay the inevitable. So we're ready, Ms. Murphy, for the vote.
Okay. Chair McDougall,
Yes.
Vice Chair Dr. Ray,
Yes.
Dr. Rosemary Jackson, I think she's muted. Dr. Miller,
Yes.
Commissioner Alam, Dr. Glover, Dr. Orto,
Yes.
Mr. Gregorio, Mr. Brown, Dr. LaRon Jackson,
Yes.
am I missing anybody?
That's it. You did say Mr. Brown. I know he's not here today, but
Right.
all right, very good. Well, this meeting is adjourned. Thank you everyone for taking the time today as usual, and a special